Hello, we are presenting a PowerPoint presentation and it is titled A Holistic Approach to End-of-Life Care. We are Group 22. Our group members are Lan Chen, Harriet Nadi, Alexis Hawk, Alexander Maranya, Noli C. Raz, and Sharanjit Singh.
In order to improve patient outcomes, our group proposes a holistic approach to end-of-life care. This approach includes educating the patient and family regarding the following topics. Number 1, physical issues involving the actual disease process and prognosis, and hospice and palliative care issues. Number 2, psychological issues, how the diagnosis affects the patient and possibly causing depression and expenses. Number 3, social and emotional issues, how the patient or disease is seen by the public or family or friends, and issues regarding death of a loving family member and bereavement issues. Number 4, family, spiritual, and religious issues, and the role of these beliefs in dealing with end of life issues, cultural beliefs, prayers, and importance of a support system. Next, ethical issues regarding organ donation and procurement, durable power of attorney, and patient's wishes. And lastly, legal issues involving the legality of VSED, or voluntary stopping of eating and drinking, versus PAD, or physician assisted death or physician assisted suicide.
Hello everyone, my name is Harriet Nadi. I'll be presenting my portion of the group presentation, and my portion will be physical issues of the palliative care. Hello everyone, my name is palliative care is whole person care that manages pain and relieves symptoms of a disease or disorder, thereby improve quality of life as the physical, spiritual, psychological, social, and emotional needs of the individual is treated. The goal of palliative care is to improve quality of life through management of patient's pain, treatment of symptoms, and improvement of health quality. It's allowing patients and family to spend meaningful and quality time, improving the spiritual and emotional well-being of both patient and family, reducing caregiver burden, allowing patient and family to express their feelings during this difficult period. The need The need to manage pain during end of life is very important because dying patients and family members desire that the dying die with dignity, and this is what palliative care aims at doing. It is making sure that death is a pain-free process, which includes the comfort care, support and relief of symptoms, making it possible for people to die with dignity. Offering the dying patient and family hope by managing their pain is the key to dying with dignity. So all pain is worth of treatment. Central to concept of palliative care is pain control. When pain is controlled, individual is able to plan for the future. Pain impacts life of chronically ill people. It creates harmful effects if poorly managed. And all pain, as I said earlier on, is worthy of treatment. Therapeutic touch can help to decrease pain. Administering pain medication as ordered by the physician will also help to alleviate the patient's pain. Utilizing alternative or complementary therapy such as music, massage can equally help to manage pain. The need. Support for caregivers. Support for caregivers is an essential part of the palliative care. Family caregivers play a very vital role because they represent the healthcare team in home by doing the assessment, all the care and management of equipment, and update the doctors and the healthcare team regarding patient's latest condition. Caregiving can be very stressful and could result into caregiving burnout. It is important and necessary that nursing help out with providing support and respite care to avoid this happening. Most often, family members are their loved ones' primary caregivers. Family caregivers plays an important part as a member of the care team and makes major life changes in order to take care of the loved ones, resulting in loss of wages and a lot of financial burdens on the family. Nurses can help by looking for support groups in the community and arranging for short-term respite care so that caregivers can take time off to enjoy themselves and have a little rest off. They can also advocate for government policies that will benefit the caregiver and the family. And furthermore, they will be there for them as by being a good listener, because by listening to the patients, they are able to develop that relationship, trusting relationship, and the therapeutic relationship between the caregiver and the nurses, and this will help in healing process. Support for care. Financial burden. Healthcare cost is very expensive, and for individuals with chronic illnesses, it is even more expensive due to their comorbidities. Caregiving is physically tasking, therefore most family caregivers quit their jobs or work part-time, resulting in loss of income. Increase in medical expenses results in financial burden to the family. So we need government policies that will pay family caregivers in order to reduce their stress and financial burden as they provide care for their family members. Although there is Family Medical Act Family Medical Leave Act, FMLA, but this gives limited support, and most people, especially part-time workers, don't take advantage of it because it will bring more economic burden to them, because when they're off, nobody pays them for those off days. So it doesn't really help that much. Communication. According to Denham et al., communication is a basic tool for exchanging information and is central to human experience. So as nurses, it is important that we provide information that is clear and effective, because it will help to establish therapeutic relationship between us and the family, also with the patient. Communication is central to human experience. Nurses should learn to provide clear and precise information regarding importance of pain management to family. Nurses should learn to provide listening ear, because this will help to create a trusting and therapeutic relationship between family and nurses. Communicating effectively with the family will result in high patient and family satisfaction. Interview with the nurse leader. According to the interview, the nurse manager defined palliative care as being offered to individuals with debilitating or terminal illness such as cancer and end-stage renal disease. Palliative care helps to relieve suffering and improve quality of life of both patient and family, and does not necessarily mean that the patient is dying, although it is not a curative. And according to her, individuals on palliative care live longer because their symptoms and pain are well managed. And the End of Life Option Act, signed into effect in 2016 by Governor Brown, may be ethically right to honor patients' dying wish, but for her, it is not morally justified. Or usually, most insurance cover palliative care, including Medicare and Medicaid, and even private insurance cover palliative care. She also pointed out that it is important to discuss financial implications with the family, so that if the family doesn't have any funding, it will be easier for the hospital to look for funding for them to cover their palliative care. And finally, palliative care is a special area and therefore has palliative care team responsible for patient care. When asked if nurses are are qualified, are well equipped to handle palliative care patients? She said no. That is why there is a palliative care team to take care of these patients. Thank you.
Introduction. Palliative care at the end of life involves meeting the physical, psychological, social, and practical needs of patients and caregivers. Providing for the psychological needs of palliative care patients and caregivers represents a unique challenge as they face the difficult reality that their illness cannot be cured, will continue to progress, and will likely cause death. Symptoms of depression, anxiety, and grief reactions can often accompany palliative patients' clinical presentation. Psychological intervention with these people include psychotherapy for depression and anxiety, stress and pain management, relaxation training, and family and group psychotherapy. Intervention. Psychotherapy is a psychological intervention that can improve coping and minimize suffering for both patients with advanced illness and their caregivers. Psychotherapy can provide a safe and structured space, as well as a symbolic container where patients and caregivers can process their feelings about the illness and the possibility of their death. Psychotherapy can be provided in conjunction with psychotropic medications or alone when medications are contraindicated or patients prefer to address their distress in non-pharmacologic ways. Intervention. Psychoeducational interventions, including counseling, behavior therapy, education and information giving, and social support will assist in ameliorating the impact of depression. Psychological interventions, including cognitive behavior therapy, education, self-care strategies, behavioral interventions, activity management, supportive psychotherapy, have all been found to ameliorate fatigue. Cognitive behavior therapy, relaxation-based interventions, such as guided imagery, progressive muscle relaxation, supportive psychotherapies, and psychoeducational strategies play an important role in pain management.
There are many social and emotional issues involved in end-of-life care. Some of them include maintaining normalcy for the patient, promoting self-care for the patient, encouraging open communication between medical staff and the family, support for the family while patient is at the end of life, providing unbiased care for the patient, and compassionate reasoning with the family. Patients receiving end-of-life care feel it is important to be in charge of what is happening to them. They would like to have a voice in the care they are receiving. Patients who are able to perform self-care and maintain normalcy while at the end of life were able to cope better than those patients who felt they were not in control. Including family members in discussions was also an important point of care to the patient. It was found that communication and the sharing of information between nursing and the family members was important to the emotional well-being of the entire family. Family meetings usually happen when the patient is moving from the curative phase to palliative phase of treatment. There is only another family meeting if it is specifically requested, which has been shown to cause anxiety among family. Family members, as well as patients, felt that adequate empathy and compassion from the nursing staff would help the transition at the end of life. It is common for the family to want to stay at the bedside once a palliative decision has been made. According to family members, this is because just seeing the patient lessens the stress and anxiety for the family. Patients at the end of life and their families are counting on the nursing staff to help them through this difficult and
Theoretical Basis, Holistic and Palliative End-of-Life Care by Sharanjit Singh. Theoretical. The World Health Organization has characterized the need for expert, palliative, and end-of-life care as a top priority for global health care. The specialty of hospice and palliative care nursing embraces a humanistic, caring, and holistic approach to patient care. We encourage the journey of end-of-life care with creating a healing environment for patients and staff members at all levels with implementation of Watson's theory of human caring. Her theory involved loving kindness, authentic presence, spirituality, being the environment, and believing in miracles. With this theory, we would encourage nurses to be more open to discussing caring and, when appropriate, prayer with the patient and family to promote unity and harmony. Jean Watson's Human Caring Science, the Theory of Nursing. Watson's human science and human care theory proposed that the purpose of nursing is to help persons gain a higher degree of harmony that fosters self-knowledge, self-reverence, self-caring, self-control, and self-healing processes while allowing diversity. Nursing in her theory was defined as transpersonal process of human-to-human attempts to protect, enhance, and preserve humanity by helping a person find meaning in illness, suffering, pain, and existence, to help another gain self-healing within, thus restoring sense of inner harmony. This leads to her Watson's curative factors. In this, she describes a lot of factors that includes humanistic, system of values, faith in having hope, sensitivity to self and others, helping through trusting human care relationships, expressing positive and negative feelings, creating problem-solving caring processes, transpersonal teaching via learning, supportive, protective, corrective mental, physical, social, cultural, and spiritual environment, human needs assistance, and existential. This leads. At this point, I would like to discuss the presence of family, spiritual, and religion in end-of-life care. In the hospital settings, we have social workers and spiritual counselors available to provide support to family and their loved ones, and making sure they have access to the resources. Spiritual care is a personal process and may include helping the patient and the family explore what death means to them, resolving unfinished business, saying goodbye to loved ones, and performing a specific religious or ritual. It is very important to follow the dying patient's religious beliefs and prayers according to their culture for patient and family satisfaction. Being able to participate in this care is not only a necessity in their lives, but also a priority for peace and harmony as they approach end of life. Watson's caring module focuses on family, and as the nurse assesses the family values, she explores these 5 key items for family experiences. These include the family's shared meaning of experiences, the family members' identity and commitment to their family identity, the family history, the family members' shared values and rituals, the family strategies for maintaining family boundaries. What sense caring? We all know how caring is important in our nursing career. In the human science and human care framework, nurses relate all familial processes to the health processes, clarifying with the family specific health beliefs, responses, and practices, and the patterns of caring each other during times of wellness or illness. According to the study conducted in Norway, the challenge of consolation nurses experience in with spiritual and existential care for the dying patients, this study revealed that the spiritual and existential care is seen to be an integral component of holistic, compassionate, and comprehensive palliative care. The nurses felt that it was very challenging to uncover the dying patient's spiritual and existential suffering because it usually emerged as elusive entanglements of physical, emotional, relational, spiritual, and existential pain. The nurses' spiritual and existential care interventions were aimed at facilitating a peaceful and harmonious death. The result of the study was very promising, as the nurses strove to help patients accept dying, settle practical affairs, and achieve reconciliation with their past, their loved ones, and with God. The nurses found this experience as very rewarding and fulfilling. Although spiritual and existential suffering at the end of the life cannot be totally eliminated, the nurses may ease some of this loneliness of dying by standing with their patients through their sufferings. Thank you.
In regards to ethical issues, it is important to first understand what is a priority, especially when it is time sensitive, especially when making decisions regarding end-of-life care. Many families may not be prepared to lose a loved one, so it is important to provide the patients and families the opportunity to verbalize what they want in the event of a life choice is needed to be made. Effectiveness of advanced care planning does solely depend on the family members' understanding, cooperation, and knowledge of the end-of-life preferences. The Patient Self-Determination Act was developed to give each and every patient the opportunity to complete an advance directive, which is composed of two components, a living will and a dual power of attorney. A living will is a legal document specifying the medical treatments one would like to receive. A dual power of attorney for healthcare designates a person to make decisions on behalf of the patient if he or she is incapable of doing so. The reason why this is being brought up in this section under ethical issues is that even with a signed advance directive, ethical issues still surface. When does ethical issues arise when it comes to organ procurement and organ donation? An ethical dilemma occurs during the process of confirming a patient to be brain dead. And is the clinical diagnosis adequate and accurate is the question. In 1980, the President Commission of Study of Ethical Problems in Medicine and the Biomedical and Behavioral Research drafted the United States Uniform Determination of Death Act, which allowed the brain death to become a legal standard. The act was approved by the Commission in 1981 and defined death as irreversible cessation of circulatory and respiratory functions, or cessation of all functions of the entire brain, including the brainstem. Even with the new legislation. Again, ethical issues still arise. Ethical issue number 2 regarding organ donation does not involve the donor patient, but the recipient of the donor. Ethical issues arise how governing agencies choose the organ recipient. Are they free from outside bias and influences? Does the cost play a factor when it comes to the recipient? And does the longevity of the person receiving the organ play a factor? Regardless of these influences that are mentioned, the agency should always base and prioritize the donor recipients based on medical need only and should be free from the other mentioned influences. An ethical issue arises when the patient has chosen to be a full code and has a poor medical outcome. For example, severe congestive heart failure, chronic kidney disease, even terminal cancer. And even with a proposed advance directive in place, what do you do as a healthcare provider when this patient has a poor outcome and is still a full code? When verbal thought processes of the patient are limited because of physiological disturbance, for example, the patient is not able to breathe on his or her own and needing artificial breathing machine, and the patient is not able to communicate, makes it more difficult to ensure patient's wishes are being followed. That is why it is important to have a medical proxy and the family there to support the wishes of the patient. Sometimes it takes the medical proxy, if appointed, to support and get involved in the situation to ensure that patient wishes are always being followed. When the patient becomes nonverbal, issues arise, especially when there's no end-of-life plans in place. That is why it's important to have people in place, for example, a healthcare proxy, who will speak for your health status in the event that you're incapacitated. The next of kin, which is specifically a husband or relative, is usually contacted, who usually makes decisions in the event that the patient is incapacitated. It is important to mention these legal standards because even with these standards in place, ethical issues still arise.
Okay, so what is VSED? VSED is voluntary stopping of eating and drinking. As an end of life option, it provides patients with a prolonged and reversible dying phase instead of the abrupt death in PAS, in physician assisted suicide, giving opportunity for reflection, family interaction, and mourning. Alright, so next we have PAD or PAS, which is physician assisted suicide or physician assisted death. Autonomy proponents believe that individuals have the right to oversee their own goals and destinies, which includes the manners and timing of their death. So, proponents believe that this is a more humane alternative uh, in dealing with end of life. Terminally ill patients may suffer from depression. In the absence of physician assisted death laws, some patients seek out other methods of suicide, such as hoarding prescription narcotics and then attempting to overdose. All right. So this slide deals with states that have physician assisted death um, laws in place, meaning it's legal. It's legal for these states uh, for physicians to prescribe medications which may hasten death. So we have California, Colorado, Oregon, Vermont, and Washington. So for the interview with the expert on the topic, I chose my boss, who is currently the director of my ICU, and she has 8 years' experience as a certified procurement transplant coordinator. So for the interview with So the optimal time to discuss hospice and palliative care is at the time when a chronic diagnosis is given. The doctor should initiate the discussion and explain certain milestones where procedures would be necessary. For example, if the heart fails, then there may be possible pressor support, or if the lungs fail, possible intubation. So the usual most likely response to a terminal diagnosis is depression and fear. The patient may also feel like they're losing control of the situation. This could push the patient to choose physician assisted suicide to give them a sense of control. The patient would feel weak also, and they may perceive that others see them as weak. The patient may also feel like they're a burden to the family, not being able to take care of themselves, especially if the patient was the main breadwinner when they were well. As far as bereavement issues, the patient should discuss with the family their wishes, such as what they want done after their death, for example, if they would like to be buried or if they'd like to be cremated, and then possible options such as organ donation, and then also they need to discuss any presence of insurance policies or if they have a burial plot prepared for them. So, religion and family, that's a very important issue. Some people have certain religious beliefs regarding their healthcare. For example, Jehovah's Witnesses, they're against blood transfusions, and so they may opt against certain procedures such as surgery if there's a possibility of losing a large amount of blood and um, possibly needing a transfusion. So this may be a possibility of uh, this patient hastening death. Also, religious requirements post mortem. So, for example, Orthodox Jews must be buried before sundown on the day they're officially declared dead. Thus, for one of Sharon's patients, they made an accommodation, officially declaring them at 12:01 a.m. That way, the family could have the maximum amount of time to prepare for burial before sundown that day. So, regarding organ donation and procurement, when do you notify the organ procurement organization? Uh, you usually notify them when brain death is imminent. Then the organ procurement organization will give the RN instructions based on the status of the patient, if they're a possible organ donor or tissue donor. Then they will follow up by talking to the family directly if the patient is a possible donor. These organizations are specifically trained to talk to families regarding end of life and organ procurement issues, and the RN must not mention the word donation to the family. Also, if the family directly asks about possible organ donation, then this is also a good opportunity to notify the organ procurement organization. Upon declaration of death, the organization is to be notified within 1 hour. Okay, so legal issues. We discussed a little bit about physician assisted death versus voluntary stopping of eating and drinking. We did note that physician assisted death is only legal in certain states, and voluntary stopping of eating and drinking um, is universally accepted as a humane way to hasten death. Um, Sometimes terminally ill patients try to commit suicide in other ways, such as hoarding pills in order to overdose. As we mentioned earlier, patients are depressed and suffering when they have their terminal diagnosis, and physician assisted death allows the terminally ill patient a dignified exit. Um, One of Sharon's cases was an elderly gentleman who tried to commit suicide multiple times, and the family was very aware and very vigilant. They would check up on him every day, call him, make sure he was okay. Then one day, the patient called all the family members and made plans with each one. This allowed them to let their guard down. And so the family did not check on the patient for a few days, and the patient was found at home uh, where he apparently hung himself. So patients will find a way to commit suicide if uh, they are in that state of mind.
This slide shows a pamphlet that was created to be used as a tool to help patients and families understand the process of end-of-life care and supporting their loved one. The second page of the pamphlet defines the differences between hospice and palliative care. It also gives what spiritual needs are and what are some patients' need arise during the end-of-life process. It also is important to maintain the patient's independence because it helps the patient cope with the process of the end of life. The pamphlet is very useful because it's an information tool to help the caregiver and the family understand the needs during the end of life. Thank you so much for listening. This concludes our project. The next two slides are the references that were used to create this project. Thanks again. Thank you so much for listening.